Can you switch? Yeah. Good morning, everyone. It's a true pleasure seeing you. Thanks for getting up so early, but I can assure you it's definitely worth it. We've heard quite a bit about the impact of blood-based biomarkers throughout the Congress as a scalable modality to aid in the diagnosis of disease and also to scale precision medicine approaches in neurodegenerative disease. And in my view, the discovery of tau217 was actually one of the major breakthroughs in neurology over the last decade. And with the recent clearance of the tau217Aβ42 ratio as a blood-based approach to detect amyloid pathology, that's really an important milestone. And it is a testament to the field that now actually there's true patient impact. And at this session, we would like to explore the clinical utility of this ratio. Where does it work well? And where is maybe further data needed in order to fully understand its value? My name is Joachim Reischer. I work at Danaher. And at Danaher, we are passionate about developing innovative diagnostics across multiple technology platforms and across several disease areas. Having said this, neurodegenerative disease, and in specifically Alzheimer's disease, is very close to our heart. And our scientists at Beckman Coulter are working relentless on developing the next generation of biomarkers and diagnostics. And also our scientists at AppChem are bringing the full antibody knowledge to bear. So we have a true powerhouse where we would like to work and where we are already working with the community to advance the field further. Now, it's my true pleasure to have two amazing speakers. The first one is Mark Suresh Calvet. Mark is a neurologist, MD, PhD. He works at the Barcelona A-beta Brain Research Center in Spain. He did research also in Munich at the Ludwig-Maximilian University. He also was a clinical associate in the London Hospital for Neurology and Neurosurgery. And he was also a fellow at the Gothenburg University. He received the ERC starting grant, which is a very prestigious grant in Europe, and also was awarded the Alzheimer Prize 2021 in Spain. Mark.
For coming here so early. My name is Marc Suarez. I will be presenting today talking about, obviously, plasma biomarkers, the phospho-tau217 and the phospho-tau217Aβ42 ratio. These are my disclosures. And I will start doing an overview about, first of all, the clinical and biological definition of Alzheimer's disease. Then I will talk about more implications, how to implement blood biomarkers, which one to choose. We have now plenty of blood biomarkers and how to use them. And I will focus a little bit about some data in cognitively normal individuals in preclinical Alzheimer's disease, which is our specialty in Barcelona Beta. Then Nick will talk about more the ratios, phospho-tau217, Aβ42, and he will show also very interesting data on this ratio and comparisons with phospho-tau217. So let's start from the beginning. I think that here we all know the ATN classification, that is the biological classification of Alzheimer's disease. But I would like to highlight that now what we tend to do in our clinics, or what we should do, in my opinion, is to use these two axes. So on the one hand, we have the clinical axis, so we have to define well in which syndrome have our patients, subjective cognitive decline, MCI, dementia, amnestic syndrome, and then we have the biological axis with the ATN classification and probably more letters coming now. In that slide, I wanted to show how things have changed with biomarkers. So in 2018, we had this criteria from Jack, and at that time we had these biomarkers, not so many, there were not blood biomarkers, but look now in the criteria that has been recently published. We have, of course, the ATN, but we start to have other biomarkers, inflammation, vascular, alpha-synuclein. Probably at some point we'll have also TDP proteinopathy, but not only this. Look at the Ts with T1 and T2. We have so many phospho-taus assays, and each of them are indicating different things. So we can really now describe very well the biological disease and also the biological staging of the disease. And this is why we have biomarkers. That's the importance. If we didn't have biomarkers, we could not do this biological classification, and we could not talk about Alzheimer's disease as a biological concept. So this is a cartoon that some years ago I was showing to indicate the different CSF biomarkers that we have indicating different physiopathological mechanisms of the disease. And I was not showing this for blood biomarkers. But now we start to have also different blood biomarkers that are really indicating different physiopathological mechanisms. Of course, the ATN, but also we have GFAP, astrocytic reactivity biomarker, very interesting, synaptic dysfunction, and others. Actually, this cartoon, I think it's already all, I have to make it new, because there are the new coming biomarkers, blood biomarkers, also indicating other mechanisms. So this is from the JACC criteria, recently published. And one of the main novelties, as most of you know, is the fact that we can use blood biomarkers to diagnose Alzheimer's disease. And obviously, we are talking about amyloid PET. This is what they call the core 1 biomarkers that are sufficient to diagnose Alzheimer's disease. Amyloid PET, we have the CSF biomarkers, the ratios of CSF biomarkers. And then we have the so-called accurate plasma biomarkers. Almost every month there is a new blood biomarker, so it's good to define a priori what is an accurate plasma biomarker, so it can be used as a core 1 biomarker that is sufficient to diagnose Alzheimer's disease. What is an accurate blood biomarker? So last year, some of us, we gathered together and we defined what is an accurate plasma biomarker, and so what is the acceptable performance criteria of a blood biomarker to be defined as an accurate. And here it's always very important to define a priori the intended use of that biomarker. We want to use it as a confirmatory test, so with this plasma biomarker is enough, you don't have to do anything else, or as a triaging test. So you first do the blood biomarker. If it is negative, you can't rule out the disease, but if it is positive, then you have to do something else to use the reference standard, amyloid PET or CSF, to confirm this. And this is the criteria that we define. So for a confirmatory test, we would need a 90% of sensitivity and 90% of specificity, while for the triaging test, the sensitivity should be the same, so we can really rule out those patients that do not have Alzheimer's disease if the result is negative, but you can be a little bit more liberal, more flexible with the specificity with 75%. Okay, so now let's talk about how we should use blood biomarkers in the clinics. Ourselves, in our hospital, Hospital del Mar, we are using now the blood biomarkers, and we have a lot of experience. We try to do research in parallel because there are still things that we don't know, but we are seeing that they work very well. However, we have now lots of blood biomarkers. Which one we should use? So this is something actually I think it will be presented also in AIC, because with the Alzheimer's Association, what we did is to, again, gather together a group, and we did a review and a meta-analysis of the main blood biomarkers that are published. And we look whether they meet this criteria of triaging test or confirmatory test as we defined it before, using as a main outcome the reference standards, amyloid PET, CSF, or in some cases neuropathology. And we did this review, we did this meta-analysis, and these are the platforms, the biomarkers that at this time meet this criteria. Of course, this is something that it's temporary. Probably these things will change. That's the data that we have now, and probably with new data, actually new data has already been published, we will have to update this table, but at the moment, this is the ones that meet that criteria. This will be published, I hope, very soon in Alzheimer's and dementia. So all of them meet the criteria for a triaging test, and at the moment there's only just one that also meets the criteria for a confirmatory test. Again, this is something that probably we will need to do every year or maybe half a year, because there are more plasma biomarkers, and more importantly, we have more data from other biomarkers. And I'm sure that some of them, the very good blood biomarkers that are not here, probably they will come here. Or can also happen the other way around, that with new data, maybe some of them that are here, then they are not meet the criteria anymore. A key thing, and something that I think that we all acknowledge, is that plasma biomarker can really contribute a lot at cost reduction, especially amyloid PET. It's expensive. CSF is not as expensive. I have to say I'm a fan of CSF, and lumbar puncture is not so expensive, but of course something that you cannot always do, and it's not only about DSA when you do a CSF, it's about lumbar puncture, and this has a cost. So a few months ago, we published this article, which was a collaboration with the Biofinder group, the University of Gothenburg, also with Nick, the Brescia group in Italy, in which we look at the Lumipulse phospho-tau217 assay. But one of the things that we did is to calculate the cost savings. And the calculation that we did is that we could save around 60% using the plasma biomarker with the 2 cutoff, compared to using CSF alone, or 80% using amyloid PET alone. This is something that actually you can calculate here. So this is a Shiny app, so you can download it if you want. It is open, and with this Shiny app, you can put the price of the amyloid PET or the CSF in your center, in your country, and then you can calculate, if using a plasma biomarker and using this 2 cutoff approach, how much would you save compared to CSF or amyloid PET alone. So this is something, of course, that has an impact on the health system. Something that sometimes we don't take too much into account is how we inform our patients about these blood biomarkers, because it is not so easy, especially with this 2 cutoff approach. So we have to inform properly our patients. So this is an example of how we do it in our hospital. We have created this kind of a diagram that actually, if anyone wants it, I can send it, and please use it freely. And actually, this cartoon, what it does is, it's like a little bit like the ATN classification. So you have in the horizontal axis the cognitive state, so subjective cognitive decline, MCI, dementia, and then in the vertical axis, like some traffic lights, you have the result of the blood biomarker using these 2 cutoffs. So low, intermediate, and high risk. So when we have a patient and we have the result of the blood biomarker, this is the cutoff that we derive with the Lumipulse assay that we published some months ago. So the patient comes, and what we do is the following. For example, we have a patient that has a dementia syndrome and has a levels of phospho-tau of 0.30. So that falls in the intermediate zone. So we say to the patient, you have a dementia, and the result of the blood test says that you have an intermediate risk that the symptoms of the dementia are due to Alzheimer's disease. Or we have a patient, for example, that has an MCI syndrome and with high levels of phospho-tau. So what we say is that you have a mild cognitive impairment, and it's very likely that this is due to Alzheimer's disease. Or we have a patient with a syndrome of subjective cognitive decline and has a very low phospho-tau217. So we say to the patient, you have some subjective cognitive problems, but it's very unlikely that this is due to Alzheimer's disease. So this is how we inform our patients about the results of blood biomarkers. If anyone wants this cartoon, it's in many languages. I'm happy to send it to you. So we have plasma biomarkers that are very accurate. It's great to have high areas under the curve, high sensitivities, specificities. But in the end, the gold standard, more than the amyloid PET or the neuropathology, is whether that has an impact in the patients, if that changes something in the management of the patient. So we started more than a year ago a study in order to see if using blood-based biomarkers in the clinics, in the routine clinics, has an impact on the management of the patients. And inspired by other studies in amyloid PET, like the IDEAS study or AMIPAT, what we did is a kind of a clinical trial in which all patients that come to our clinics, all of them prospectively, we randomize in an early arm in which we disclose the result of the blood biomarker early. So this is the early arm. So before 3 months, we do all the routine things that we do, the clinical history, a cognitive test, a CT scan, a general blood test, and then we do the blood biomarkers, and before 3 months, we give the result to the patient and to the neurology. This is the early arm of the study. And then we have a late arm in which we provide this information, the result of the blood biomarker, to the neurologist and to the patient half a year later. Then we follow them, and we compared if there is a change in the management of the patients, comparing the early disclosure arm and the late disclosure arm. And what we find is the following. This is very preliminary data, but this, what you can see here in this graph, in blue, this is the early arm, and in purple, the late disclosure arm. And what you can see here is that in the early arm, we start acetylcholinesterase inhibitors, much earlier than in the late arm. So this is something that has an impact in the patient. We start a specific treatment for Alzheimer's disease much sooner if we use the blood biomarkers as soon as possible. Not only this, what we also see is that in the late arm, we do more cognitive tests because probably, as we don't know, we are not sure about what is the diagnosis of the patients. We do more follow-ups, we do more cognitive tests until we reach a diagnosis, less than in the early arm. And also what we see is that in the early arm, we discharge more patients. Most of these patients have low levels of phospho-tau217 because we are quite sure that the symptoms that they have are not due to Alzheimer's disease, so there's a more rate of discharge of the patients. Of course, this also have an impact not only in the patient, but also in the healthcare system. So using blood biomarkers, especially if you apply it early, also have an impact in the management of the patient. So cognitively unimpaired individuals, preclinical Alzheimer's disease. So this is a work that actually we did with Nick some years ago. It was not so long ago, so it was in 2022, but things have changed a lot. But I want to show this area under the curves that at that time we were very happy to see this because we are talking about plasma biomarkers in cognitively normal people, and we had some area under the curves that were at that time quite decent, around 0.7. These were mainly using CMU assays, except the phospho-tau217, which is the Lilly MSD assay. And so we were quite happy at that time with this. But things have changed a lot, and now we have other assays. This is from the Biofinder group. This is the mass spec assay, and look not only in cognitively impaired individuals, but in cognitively unimpaired individuals, the performance of plasma phospho-tau217 is similar to the CSF with accuracies that are extremely high. But not only in using mass spec, but also using some immunoassays. Now we have also some assays that are very accurate. So this is our alpha study in Barcelona Beta, in which we look at cognitively normal individuals. We have amyloid PET. This is a longitudinal study. So we have 2 visits, visit 1 and visit 2. And I will show data first of the visit 1, whether some of the plasma biomarkers are able to discriminate between amyloid positive and negative, as described by amyloid PET, and also some longitudinal data. So we measure, this is data from the NTK of Roche, measuring different biomarkers, including, and now we start with the ratio, some of the ratios, 217 and Aβ42, and also, of course, the single biomarkers. So these are the results. This is results from Armand Gonzalez, a PhD in my lab. And look at this number. So maybe it's a little bit small, but look at phospho-tau217, Aβ42, an area under the curve of 0.94. Or 217 alone, let's see if I find it, yeah, 0.91. So in just a few years, things have changed dramatically. And what was acceptable some years ago, 0.7, now we have really an area under the curves and accuracies that are much, much, much higher. So here, as you see, the ratio is a little bit better, and actually if we do a statistical analysis, we see that 217 is indeed better than, the ratio is better than 217 alone. But we can discuss later the advantages and disadvantages of using the ratio versus the 217 alone. This is the longitudinal data. So changes in these biomarkers, longitudinal changes in 3 years, 2 time points, and changes in amyloid PET. And we see that there is a nice correlation with the change of plasma biomarker and the change in amyloid deposition as measured by centiloids. Of course, when someone sees that, the first thing you have in mind is, because we need a monitoring biomarker, especially in the area of new treatments. And this is a very nice correlation. However, this is at the group level. At the individual level, I think that we are not yet in the time in which we can use an individual level in a patient really to predict whether this will be a change in amyloid deposition. But well, the data looks good at the moment, at least at the group level. Always, let's have to take into account that some comorbidities are affected. Here, you can look at the renal function, and more or less all the biomarkers are affected by renal function, but the fact of having ratios, then this helps to ameliorate the effect of changes in renal function in the levels of biomarkers. Also, things like BMI affect some of the biomarkers, especially the phospho-tau181, even if you use the ratio. Lately, something I want to explain also, there's a subset of patients that I think that are mostly neglected and extremely interesting, which is the subjective cognitive decline. Actually, this is very common in the clinics. People come to the clinics, they're saying, I have some complaints. Actually, all of us, at some point, maybe in our life, we have feel that we have problems with memory, but then you go to the neurologist or to your physician, you do cognitive tests, and everything is normal. And actually, luckily, these people do not have Alzheimer's disease. But it's very important, it's key really to detect these patients that will evolve to Alzheimer's disease as soon as possible. So in Barcelona, we have a cohort which is called Beta-ARC, Alzheimer's at Risk, which is a cohort of subjective cognitive decline that we follow longitudinally, and we have now data of the cross-sectional study. Here we measure a lot of biomarkers, some of them measured in the University of Gothenburg. I will not go through all the single biomarkers, but the point here is that some of them, again, in subjective cognitive decline, they have also a high accuracy to detect amyloid pathology. In that case, using as a reference standard the CSF. But something that I would like to highlight here is that when we interpret a plasma biomarker and any biomarker, it's not enough to take into account the area under the curve, the sensitivity of the specificity, but it's very important to take into account the pretest probability of having this disease, in that case, Alzheimer's disease. Because what it matters in the clinic is the predictive values. So you have a positive value, what is the chance that having a positive test you will have Alzheimer's disease. So that's the positive predictive value. Or if it is negative, the test, what is the probability that you don't have Alzheimer's disease? And this is dependent not only on the metrics or the performance of the test, but also of the pretest probability. And in a population like subjective cognitive decline, in which obviously the prevalence of Alzheimer's disease, so the pretest probability, it's lower than in a memory clinic, then what it happens is that although many of these biomarkers have a very good area under the curve, the positive predictive value is low, while the negative predictive value is very, very high. So these are things to take into account in the clinics. Actually, based on that, and this is a personal opinion, I would use blood biomarkers in subjective cognitive decline to rule out the disease, because you have a high negative predictive value, but not to rule in to confirm the disease. But this is probably something to discuss, because many people, and I understand, prefer not to use plasma biomarkers or biomarkers in general in subjective cognitive decline. So this can be discussed. Okay, so with that, I arrived to the conclusion. So we have several plasma biomarkers that indicate not only ATN, but different pathophysiological mechanisms in Alzheimer's disease. It's important that for clinical utility, plasma biomarkers have to show that are comparable to the reference standards, which are still amyloid PET and CSF. For tau217, we have a lot of data that shows that really have a high accuracy to detect Alzheimer's disease in cognitively impaired individuals. But not only this has an impact using plasma biomarkers in the management of the patients and, of course, also reduce costs in the healthcare systems. We can identify also amyloid pathology with blood biomarkers in cognitively unimpaired individuals, not only with mass spec, but now we have some very good immunoassays. And we also need to take into account in the clinics the predictive values more than the metrics, the performance of the assay, especially in cases like subjective cognitive decline. And with that, I will finish. Thank you very much.
Thank you so much, Mark. Excellent presentation. We have time for a few questions for understanding, and at the end of the session, we have more time for discussion plans. So are there any questions right now for Mark? I have one, actually. So I like very much this chart, how you explain the dual cutoff. How do patients react to that? And
I think that you have to understand it well, so you need some time. We have a population that most of them are very low education. Some people even cannot read and write. So that's why we did that. So a very graphical thing so people can understand it. But I think that with biomarkers, it's very important to inform before you disclose the patient what is it. So patients know what to expect about what is the information that we will give. That is especially important because in former times with amyloid PET and CSF, this is a big test. Then we gave a lot of explanations to our patients about asking an amyloid PET. But as blood biomarker is something quite easy, sometimes we don't do the effort to explain what is the implications of doing a blood biomarker. But the implications is exactly the same as an amyloid PET. You will say to the patient that has Alzheimer or not. So this is why it's very important to have time to explain to the patients and the caregivers before and after what is the implication of blood biomarkers. And I believe these things can help.
Absolutely. Thank you. Yes?
Hi.
I really like your trajectory data. I love your trajectory data with the cognitively unimpaired. But as you said, it's on a group level. What additional information or what additional data is needed to be able to convert that to something that can be action for individual patients to tell people not just that they have amyloid pathology, but that they are progressing toward symptomatic AD?
One thing is a prognostic biomarker, so a level of biomarker that will predict whether you will decline. And another thing is a monitoring biomarker in which you do different measurements, and then you can really monitor the amyloid deposition or cognitive changes. For prognostic biomarkers, if you have in general higher levels of these biomarkers, 217, actually you have more decline. But again, whether you can use it at the individual level, I think we are not still at the point. For monitoring, I think that probably we'll have to go to combining different biomarkers that are really showing different stages of Alzheimer's disease. With phospho-tau217, maybe we'll have better biomarkers in the future, maybe with the brain-derived phospho-tau217, but I think that here there's a lot of work to do for monitoring biomarkers. Yeah.
One question here? The microphone? Can we get the microphone here?
It's okay. I will just speak loudly. So I realized you use a different method, Roche, Samora, etc. They have different cutoff values. When you deal with the multi-centers, how would you deal with this standardized, this cutoff value?
Well, at the moment, we must use, we cannot pull data. I mean, there are some efforts in order to harmonize this data, and like, a great idea is what in amyloid PET field they do that with using the centiloid, so you can use different radio tracers, but then there is the centiloid scale. At some point, maybe we have a reference, so we can all the assays can be compared to that reference, as it has happened with other tests in clinical chemistry, and then we have the similar. But at the moment, I think that we have to use cutoff specific for each of the platforms.
So you don't use, for example, the mathematical formula to convert it from one way or another?
I would be very careful with that, with this formula. Of course, you can do a formula. You have your cohort, you measure the biomarkers with different platforms, and you can, of course, calculate a formula. But whether this formula you can apply it in a different cohort, not to say in a different center or in a hospital to the diagnosis, I would be extremely careful with that.
Good. Thank you so much. We now need to move on to the next speaker.
Sure.
The next speaker is Nick Ashton. He is currently Senior Director and is leading the Fluid Biomarker Program at Banner Research. Nick did his PhD at King's College in London, and he also was an associate professor at the University of Gothenburg, so it seems a lot of talents coming out of Gothenburg. Nick has an amazing publication record. He has more than 20 publications and was also ranked as one of the highest cited researchers globally. And he also won the Queen of Sweden Prize, which is dedicated to outstanding young Alzheimer's disease researchers. So, Nick, please.
Okay, thank you for the invitation. Thank you for turning up and coming. And for those that decided to stay in bed online, I won't hold it against you. We'll never know who you are, so that's fine. So I'm going to follow on from Mark and start looking at some data in the ratio, and I want to have a bit more of a pragmatic discussion about what are the benefits and what are the negatives about using a ratio. And we have two different pathologies in this ratio. We have something that detects phosphorylated tau, and we have something that detects amyloid beta, and they're different. And maybe we need to understand what these biomarkers do individually before we start putting them in a ratio. So discuss that in a little bit more detail. So I'm not a clinician, I'm a researcher, so everything I do, I don't see it in a patient, we just see it on Excel sheets and code. So I'm coming more from a research angle, and I think it's nice you've heard from Mark's perspective as a clinician, and we can try and put these together. So these are my disclosures. So the overview of this is that, again, we're just going to reiterate the importance of phospho-tau217. And then I want to look specifically at Aβ42 and 40 alone in plasma, and what do we know about that before we start combining it with phosphorylated tau. And then we'll start looking at some ratio data with the FDA-approved test and other types, and also the Beckman-Coulter versions of 217 in the ratio. And then at the end, Mark and I have put together some what we think are advantages and disadvantages of using the ratio. What should we consider? We'll leave them up and see if you agree or disagree. We're open to feedback, aren't we, Mark, I think? So the first thing to point out is that using a ratio is extremely common in CSF biomarkers. We use it all the time. Actually, our FDA-approved tests in CSF are ratios. We have Aβ42/40 ratio. We have phospho-tau of Aβ42, total tau of Aβ42. And the reason around that is that we have some anomalies if you use single biomarkers around CSF dynamics, different diseases, where you need to normalize to the inter-individual variation in these biomarkers. That's why we use it in CSF. So a good example of this is an Aβ42 in CSF will decrease in inflammation-related disorders. So the likely scenario is if someone comes into a clinic and they have decreased Aβ42, you won't be able to definitively say this is because of Alzheimer's disease or an ongoing inflammatory disease. Now, clinically, that's not really an indication, but it gives you the point that the physiology of these biomarkers are different in different indications. So we use Aβ40 to vary or normalize what in people's individual APP processing. Because even outside of disease, people process Aβ at different rates, at different levels. So you need a way to normalize into individually. How does that do? That's what Aβ40 does, and helps us with Aβ42. You can also use the ratios for greater accuracy. So once you do normalize, and whether you use 42 over a phospho-tau ratio or 42 over 40, you see a much better concordance with amyloid PET or neuropathology. So not only is it normalizing individual differences, it's also helping us with greater accuracy. So ratios are not unheard of. So it's not a huge surprise that we have something also in blood. The way that we use biomarkers in clinical chemistry is not really what we do in research, where we try and come up with diagnostic models and algorithms. We actually look at these biomarkers individually because they're telling us individual information. So clinical chemistry in Gothenburg, if the idea is that someone has Alzheimer's disease, we're looking for a decreased ratio, we're looking for an increased phosphorylated tau, and we're looking for an increased total tau. All those boxes are ticked, that gives us great confidence. If just one of those boxes are ticked, it means something completely different. So if Aβ42, 40 ratio is normal, but you see high total tau, or very, very high total tau, that could be Creutzfeldt-Jakob disease or something, a very aggressive type of dementia. It's not indicating Alzheimer's disease. So these biomarkers have individual information that need to be looked at separately, in my opinion. Now, this is easier in CSF. Concentrations are higher. The results are much, much clearer. When you go into blood, it gets a little bit more difficult, but as Mark has shown, we've made a tremendous amount of progress. So here's one of these many, many head-to-head papers that have been produced over the last few years. This is probably one of the most recent from Mark's group that we did together, showing that basically measuring phosphorylated tau in plasma has the highest diagnostic utility than any other phosphorylated assay that's out there. I think there was some debate about how good is the assay versus how specific is the biomarker, but I think we're all clear that actually detecting the 217 epitope gives us a clearer diagnostic utility. To answer this gentleman's question at the end there, now there is a big effort from the GBSC to standardize all these tests. So this takes a long time. You have to do commutability studies, which are extremely boring, which is why I didn't include it in this one, because it is early and I want you to stay awake. But the idea about a standardization commutability study is that you design a reference method and a reference standard. So artificial peptides that are specifically phosphorylated on 217, you measure them with all the assays, and then you bring all the assays to a single point. So whether you measure 217 on the FDA-approved Lumipulse or on Roche, they should all come to the same single point. Now, this takes a long time, but this is what we've done for CSF Aβ40 and Aβ42, that all assays have to calibrate to this single point. So not great news for companies, because that means that you can use any assay, but great for standardization across labs across the world, that it doesn't really matter what assay you use, you should be able to get to the same point. So that effort is ongoing, but it takes some time. So how does Aβ40 or 42 ratio look like in Alzheimer's disease when we don't look at phosphorylated tau? So this has been well studied for a long time in research. And I would say up until maybe the last year or so, the research community had kind of given up on Aβ in plasma. That would be my conclusion. This is really why. This is data you can download from the ALZ-Forum database, which is measuring Aβ42 or the 40 ratio using different assays over different studies over many years. So what you can see is basically the one line here, which is no change, and you see that different studies have basically found no change, some that have found increased, some found a decreased, and it was a little bit messy. And the quite simple answer is that we do have a lot of peripheral Aβ that we produce. Some comes from the brain, but the majority that we pick up is from peripheral production of APP. Now, if you see at the bottom of this graph, you start to see a little bit of a change. This is the Sabara assay published in 2016, where we start to see that this ratio starts to decrease in plasma if you have amyloid PET in the brain. So this was a bit of a change in trend in the field that then from this point, we did start to see consistent results where the ratio was decreasing in plasma, just like we expect in cerebral spinal fluid. And this is a bit more of an updated version of this now, where you can see that the accuracies of measuring Aβ42 with different methods, again, still varies hugely. We don't see this with phosphorylated tau, where you see very consistent high accuracies. But you do now have some methods, immunoassays and mass spectrometry methods, that have high accuracy when you measure the Aβ42/40 ratio. So this has really changed in the field. But it is a much, much bigger decision for the assay that you choose for Aβ than it would be for phosphorylated tau. That's very, very clear. Now, this is the main concern about measuring Aβ alone. And this is something we know a lot about, and it's something that we will discuss probably a lot today. So this is same individuals that have been measured on an Aβ42/40 in cerebral spinal fluid and also plasma, and they're compared against amyloid PET. And this is being measured by a mass spectrometry method, which I think is probably the gold standard for this protein in plasma. So what they both show is very good accuracy to discriminate amyloid negative and amyloid positive. But you see on the left-hand side is plasma, and there's about a 10 to 12% change if you have amyloid positivity in the brain. If you compare that to the CSF in the same patients, you have a 50 to 60% change. So there's a big difference, not only in the accuracy, but also the dynamic range of the biomarker when you change to the biofluids. Now, this is not necessarily an issue, but it is an issue if you don't have an assay that is under your biological change. So if you have an assay that exceeds 10%, you're going to be kind of flirting with what the biological change in that biomarker is over time. So essentially what I'm saying is that if you have you're measuring Aβ42 alone, you need to have extremely good reproducibility and high precision assay in order to do this measuring. But it's not impossible. Different methods matter. So this is a more correlation, voxel-wise plot. So you're correlating the fluid biomarker to amyloid deposition in different brain regions. Again, this is in the same individuals. What you can clearly see from just visually is that the mass spectrometry method of measuring Aβ42 correlates much highly with what the amyloid deposition is across the brain, whereas the SAMAR assay has much lesser correlation. So this was done a number of years ago. And again, this is probably down to the specificity of the assay that we're using. You know, mass spectrometry, we measure the peptide level. We know exactly it's 1 to 42 amino acids, whereas the immunoassay, you have an epitope and you're making some assumptions that the peptide that you're measuring is 1 to 42. But I think there is a general consensus that if you can measure Aβ42/40 correctly, that it's the earliest change that we can detect in disease. So this is work we did with Mark. He's shown this paper already, but I'm showing a different figure. And we can see with just very, very low levels of amyloid deposition, we see that Aβ42 is starting to decrease. It wasn't with Mark, it was with Oscar Hansen. So if I'll show Mark's afterwards. So it is very sensitive to change. So again, to my point is if you can measure it accurately, this is a very early biomarker, maybe it precedes phosphorylated tau. And that would make sense based on what we know about the disease of Alzheimer's disease. Aβ should precede tau. Now this is Mark's paper recently. And this is our major concern about looking at Aβ as an individual biomarker, is that although it's very sensitive and highly accurate, if you have any sort of variation in your data and in your assay, you lose your diagnostic accuracy of the biomarker. So this is robustness and bias models that Mark and his team have developed. And what you're looking at is, if you take the plot on the left here, you see that actually Aβ42/40, at the actual measurement time and very well-controlled study, it is the highest accurate biomarker to determine amyloid PET by CSF. That's what Mark has shown. But as you increase the variability, and that variability can come from your assay measurement, it can come from potentially pre-analytics in the way that the blood was collected, it can come from various sources. But as that CV starts to increase, the diagnostic accuracy, as you can see, starts to plummet and go down. Whereas the other biomarkers like phosphorylated tau, because they change by over 3 to 350% and have a huge change, that they are less susceptible to variations of this type. I've kind of explained this. There are some pre-analytic concerns for A-beta, whether you how long you leave the tube on the bench, what type of tube that you use, the speed that you centrifuge it, again, all boring stuff. But this is a real concern if you want to use this in primary care, where you cannot guarantee that the guidelines that we set out will be followed. If a biomarker is so sensitive to this, it's something we need to also consider. And the third thing is that we have some pharmacodynamic effects on A-beta, which we can detect in plasma. So this is FDA-approved neprilysin inhibitor for cardiac failure. And what you can very, very clearly see on the right-hand side is that it degrades A-beta. And you have a reduced A-beta 42/40 ratio. And it looks like, if I didn't put the mode of action on the top, you would have thought that maybe this is an Alzheimer's disease study, controls versus disease, because that's what it looks like. So we need to actually understand, you need to have that information from your patient that they're on some of these drugs, because it would be a problem by using A-beta 42 in this context. So there are a few pharmacodynamic issues as well. So we have a presentation this afternoon. This is Marissa in my lab. She's also here if you want an inside scoop before she presents. Is that we have moved away now from research platforms like Simoa, and which have really led the way in developing and showing that these assays work, but more to IVD platforms. How do we measure thousands and thousands of individuals quickly, robustly, with high precision? So Marissa has now been comparing some of these assays for phospho-tau217. These are the ones that will be the leaders in the field over the coming years. And in our lab, we've measured it in over 6,000 individuals across all the platforms. And Marissa will be presenting some of this data today. But what does this show? Now, I think the assumption was 5 or 6 years ago is that we needed a high-precision, ultra-sensitive new technology to measure 217 accurately and correctly. And it would be a struggle to get it on something like a Roche instrument or a Beckman-Coulter instrument, to these large instruments that also measure IgG and CRP and all these things. But that's simply not true, and this is why. Because the accuracies are extremely good. So on the left-hand side, we have all individuals. They're classified by amyloid PET, 24 centiloids, which is an arbitrary but agreed upon cutoff for what is amyloid positive. And that's another discussion. This is not something I can explain or argue for you. Maybe Mark can. But the 24 centiloids is a modest cutoff for what we think is amyloid positive. I think there's some trials have used 37, which would be more advanced, and there's some individuals that say 12 centiloids is also a cutoff, but 24 is a nice median here. So what we see with all these IVD platforms, good accuracy to determine amyloid PET. Now, also to support Mark's point, what he's also shown, we see very, very little change if you just restrict that to cognitively unimpaired individuals. The accuracy is still extremely high. My interpretation of this is that the biomarker reflects pathology. So if the pathology is 24 centiloids, it doesn't really matter if you're symptomatic or asymptomatic. The cutoff should be the same. The underlying thing that we're missing here is that a person with symptoms is more likely to have neurofibrillary tau pathology, and that also acts on our biomarker, and that's why we would maybe see those levels to be higher. Now, what we can see here is that also what Mark has shown is that if you use a ratio, and actually we've played around with this, it doesn't actually matter what A-beta 42 you use. If you do any sort of combination of 42 to 217 ratio, you substantially improve the diagnostic and the area under the curve of the assay. So completely in line with what Mark says, completely in line with what the FDA-approved test. We see exactly the same thing. And that works in cognitively unimpaired or symptomatic individuals. One of the unique things here we see with our data is that we have longitudinal samples over 10 years. And this is a snapshot of the data, and I think this is the Beckman assay for 217 alone, yes, and the Fujio Bio 217. So previously I said that the diagnostic accuracy was very, very similar, but you can see just very visually from this graph that longitudinal change may be different in these biomarkers. Can't explain why that is. They are detecting the same phosphoepitope, But these assays are designed differently. They have different detector antibodies. They are measuring different fragments of the tau protein. So we can see from the 217 on the Beckman, we see that there is a much steeper increase over time than a different assay, which is detecting the same thing. So there are some differences when we start to look at longitudinal data. And I think it's perfectly acceptable for us to say that these are the assays we use for diagnostics, but if you're interested in longitudinal change or prognosis, that these are the assays that we would use. We've done this in CSF for years, where we recommend different assays for different contexts of use in research. Now, this is data that's provided to me, and this is, again, now specifically looking at the Beckman 217 assay with also their Beckman Aβ42 ratio. And again, the story is extremely consistent here, is that you have a good accuracy of 217, but that accuracy is statistically improved if you use a ratio with Aβ42. Something we haven't discussed here, and this is probably the main argument for the FDA-cleared test, is that, as Mark described, that we have 3 categories that we recommend to diagnose our patients who have high and intermediate and low. And high and low are easy things for us to determine. If there's symptoms, we can then classify these people based on their symptoms, but also maybe their pathology. And then there's treatment decisions there. If they're in high, the potential that they can receive an anti-amyloid therapy. If they're low, remember that they have symptoms, so they go through a different diagnostic story and to investigate for other types of causes of dementia. But what do we do with this intermediate zone? That's the big issue here. And what does the intermediate zone mean? Actually, I think most of our research shows us that they just have intermediate pathology. It's not an inaccurate measurement of a blood biomarker. It's just at the stage that they're at. We have very defined cutoffs for CSF. We have very defined cutoffs for PET. But the blood biomarker, we just can't be confident around that single cutoff. So a blood biomarker needs to make that intermediate zone as small as possible, because those are the individuals that maybe we need to refer for CSF and PET. So for cost purposes, for clarity, you want to be able to make that zone as small as possible so less people have to go through an additional diagnostic journey. So very, very clearly from this graph, you can see that that's another very strong argument for using a ratio, is that you reduce this intermediate zone. This is quite a large intermediate zone for 217. In our data, we see it a bit smaller than this, but about around 25% would be in this intermediate zone if you use 217 alone, whereas with the ratio, with multiple data, including this, you can reduce that down to about 10%. So 10% of individuals would need confirmatory test, or some people would recommend that you see them a year later and do the same test to see if they progress. Another use case for the ratio, this is in our paper with Mark, which we published in Nature Medicine earlier this year, and the Biofinder group, using the research-only use versions of the FDA-cleared test. So this is not the IVD version. And we've tested them in different contexts of use. So secondary care, so specialist care, where Mark would see patients, but also then in primary care, what's the case used for using the ratio in primary care? And we can see that here, the ratio really starts to improve our negative predictive value. Just like Mark has said, we can use this ratio as a very, very high rule-out biomarker to suggest that this is not Alzheimer's disease pathology at play. But the positive predictive value of the ratio, as you can see from here, is not as good as 217 alone. So as Mark and I were just discussing earlier, it's great to have these biomarkers on the individual level. We can use the ratio, but it's also great for us to see what's happening with 217. It's also great for us to see what's happening with Aβ42 because of this and other pharmacodynamic indications. Again, we see that using the ratio substantially decreases this intermediate zone. So this is the bar on the right. The striped bar is the ratio. The solid bars are 217 alone. And we, in our study in secondary and primary care, we see that this intermediate zone is around 15%, so a lot smaller than what we previously showed. But the story is the same, is that you can shrink this intermediate zone by half if you use a ratio. This is Mark's data. He's already shown it. And again, it's just another use case that the ratio improves the accuracy, but also in cognitively unimpaired individuals. Can't remember exactly which one you showed, Mark, but if you look at the one on the left, these are the same individuals that have been classified by CSF, but also by PET. And you can see that different biomarkers in blood work differently based on what your standard of truth is. So in the CSF here, we actually see that one of the highest or the highest accuracy is actually just using Aβ4240 alone. Whereas if you classify with PET, which again is a different pathology, this is solid amyloid plaque pathology. The CSF is more kind of a state marker of oligomeric Aβ. The biomarkers work a little bit differently. So it is very important what your standard of truth is and setting cutoffs based on that. I think we would get a very messy cutoff if we start merging data that are classified by CSF and some by PET. So that's something for us to consider. So I'm going to just switch gears slightly for the last slide. And if you're following blood biomarkers, you're going to be extremely confused because you have 217, we have a ratio, we have N-terminal tau, we have high molecular weight tau, we have low molecular weight tau, and now people will talk about brain-derived tau, and now people will talk about brain-derived tau, phospho-tau217. So what does that mean? So I will try and explain this as best as I can. So we have two types of tau. We have brain tau, which is the tau that we see on the top here, but we also have peripheral tau, and we call this big tau. This has a huge insert of about 110 amino acids which are peripherally expressed. Now, most of our immunoassays are pulling down phospho-tau217, and the detector antibody is at the N-terminus, between about 6 to 18 amino acids or variations of that. So what does that mean in reality? So if you have a lot of peripheral tau being expressed for whatever reason, that these immunoassays cannot differentiate what is brain tau and what is peripheral tau. That's the basics of that. But if you have an antibody that's specifically raised at this exon 4 junction and can ignore big tau, then you have a much more specific assay that you know that what you're getting is brain-derived 217 tau. Now, so this is a very extreme example of how this would work. Of course, ALS and Alzheimer's disease is never going to be a clinical conundrum, but it's a proof of principle here, is that these are the same individuals that have been measured with a brain-derived tau here, molecular weight tau, which is actually the Lilly assay, which has been produced with that in mind. It's been around for a while. And a non-specific one, like the ALZpath assay on the Quanterix platform, which is a high molecular weight tau. It detects both. So in ALS individuals, you do have a lot of peripheral tau expressed. And you can see from this that you would get a lot of individuals where peripheral tau affects the assay, and it looks like the ALS patients have the same levels of what we have at Alzheimer's disease. But if you look at the brain-derived tau, the same individuals' ALS is not increased. They are low, and that's what we would expect in ALS. If you look at these assays in the cerebrospinal fluid of these same patients, they're all negative using both assays. So that tells us that this is a peripheral phenomenon, and maybe there is some specificity here that we can improve in our test. I think that this is very, very useful for clinic, because when we have people coming in primary care, they're going to be sicker, they're going to be very heterogeneous. Peripheral tau from neuropathies and other indications could likely be an issue. I think for mine and Mark's research, where we potentially look in unimpaired individuals, we may struggle here because the sensitivity issue for brain-derived tau is going to be very, very low. And it's one of the reasons why the Lilly assay, although it's very, very good, hasn't been used so much in research, because you see a number of individuals that are asymptomatic below the LLOD of the assay, and we've interpreted that it's not a good assay. I think it's just a very specific assay. So for longitudinal change, we may need to assay designs. But versions of these assays are on the way from various different sources, and I think this is going to be a really good clinical assay for us to use in primary care. So this is the slide that we've come up with. Don't read too much into it, that there's more in the disadvantages than the advantages, because I think that the advantages hold more weight to them. So maybe we should have added some weighting to this, Mark, maybe actually instead. So this is what I think we would like to discuss, and this is the data that we've presented, is that using a ratio improves the accuracy and the concordance with amyloid PET and CSF. this happens in cognitively unimpaired individuals, it happens in cognitively impaired individuals, and I think Mark and I, between us, have shown already 6 or 7 different studies where this is the case. There are studies, but I only showed one, where using the ratio improves your negative predictive value of the biomarker, and I think that's the primary indication of what we want in care. We want to rule out that Alzheimer's disease is not the cause of the symptoms, and that we would use a confirmatory test to show that it's actually Alzheimer's disease, and maybe they can get therapy. And all the studies that we've shown and that are out there show that this intermediate zone, this undeterminate group, you can reduce from around 25% to about 10% if you use a ratio. And there's some disadvantages, and none of this is about the data. This is about Aβ42 as an individual biomarker, not about the ratio. There are pre-analytical concerns around Aβ42, and these pre-analytical concerns are concerns because the minimal change we see in this biomarker is small. There are definitely pharmacodynamic effects on Aβ42, specifically in the plasma, that we need to know about and we need to look out for. We haven't talked about this, but we are doing certified reference materials and standardization for Aβ42. This was already tried for Aβ40 5-6 years ago and was determined by the International Federation of Clinical Chemistry that it was impossible to do because none of these assays correlate with each other to a high enough degree. And then I guess that the companies would argue against me about this, but being a biomarker researcher, it's easier to control one assay than it is to control two, lot to lot, and variability over time. And I know that from personal experience. So I think we'll finish there. This is my group and all the collaborators. Maybe I should go back to that slide. Maybe we should have it up. And thank you for listening.
Thank you so much, Nick, for this very insightful presentation and giving us a sneak preview of Marissa's presentation later today. Looking forward to it as well. Yeah, are there any questions to Nick and or Mark? If you think about the current body of scientific evidence, what would be the study that you would like to do to shed more light on the ratio and how to further sort of validate it and identify the different clinical context of uses?
I think from the clinical point of view, not only for the ratio, but for in general plasma biomarkers, we need to do more prospective studies because most of the studies have been done with retrospective samples that many of us will have in our course. So we need to do more prospective studies. And then I would say that we have to enter in the phase 4 of clinical trials. So use the plasma biomarkers in the reality. That means to implement them in our clinics. But while we use them, and I think that we have to use them because they are working very well. But while we use them, also do research. That's why sometimes I think that we still have to do some lumbar punctures to have the reference standard and learn more about it. We have seen some drugs that affect some of the levels. And I'm sure there are other drugs, other comorbidities, or other things that we do not know because all the studies that we have done are in research studies. So we need to put them in practice and do research on this. And I'm sure we will realize things that we didn't know. And with the ratio, exactly the same. So we need to do prospective studies and see whether there are also differences with prospective measurements, also with more heterogeneous populations.
Great, thanks.
Yeah, a question for Nick. I'd ask Mark about the predictive value of these markers. And you said in your presentation that you think the intermediate range is reflective of intermediate pathology. So does that mean that these people are more likely to progress to positive? And if so, do you have data showing what the rates of progression are for those individuals in the intermediate range?
Yeah, it's a good question. We do have that data. I guess we just haven't synthesized it properly. So I don't know the exact rates of those in the intermediate. But what I was trying to say is that these are the guys that are hovering around 24, 25 centiloids or 23, 24. So it's true that they are truly intermediate. We just have a better refined cutoffs in PET because you're looking at the direct pathology. So it is probably true that these individuals are likely, they would be in a different category if your centiloid was 20 or your centiloid cutoff was 12. They would probably be in the high category. Whether they progress quicker is something I don't know, but my assumption is that they would be because there is a substantial amount of pathology in their brain. We have a lot of study on amyloid clocks. That I think there's a big session on amyloid clocks, and what that data suggests is that once amyloid starts accumulating, it's exponential. So if you have people that are amyloid negative, I think Mark has also shown these people do not move. They stay amyloid negative, and the blood biomarkers stay that as well. If you have a little bit of amyloid, and that starts to kind of grow exponentially, you start to see the blood biomarker also increase. So my assumption, without actually knowing, is that these people in the intermediate zone, if they are truly intermediate and the cutoffs have classified them correctly, that they are just in that kind of phase and they will eventually end up in the high group.
Good morning. I am a primary care provider. I work in implementing biomarkers in primary care clinics at Indiana University, and cost remain a main barrier for doing this. What strategies have you used in the real world to scale the implementation of blood biomarker testing?
This was around cost. The cost is a limitation. Yeah, I don't know how to answer that. But there's a big, from a United States perspective, there's still a huge discussion on what is the price point for this. And I think this is going to be resolved very soon, actually. From the scalability is that we now have platforms where you can do ad hoc testing, which we couldn't do 2 or 3 years ago. We had to collect a bunch of people and plate-based assays, and we had to fill these plates for it to be cost-effective. We couldn't do 2 patients that day and 5 patients that day. We can do that now, and that will help with scalability and it will help with cost. Not sure from a European perspective about price points and how that's been worked out.
I think, of course, I'm not from the industry, so I cannot talk about prices but I guess and I hope that if we start using it more and more, as it happens with other blood tests, other blood tests, maybe the prices will go down. I hope this, of course, I don't know. In the end, it's the blood test itself is not more expensive, I would say, than the CSF. So I hope that in the future, if we use it more routinely, the costs are going down. And of course, it's much cheaper than an amyloid PET. And not the CSF test, but all what involves around doing a lumbar puncture.
And so we also haven't resolved of how is it going to be reimbursed and not reimbursed. So you don't need an FDA-approved test to use it clinically. You can have a laboratory-developed test. So we have been using blood tests in clinic for over a year.
Yeah.
But these have been all out of pocket on the patient, and still today, that's still the case.
There's a question. Last question, then we are nearing the end of this session.
Yeah, thanks for the talk, very nice. I have a comment about using ratio as a diagnostic. We've been doing CSF diagnosis in Australia for years, and what we have observed, I know the ratio is good that you get a better correlation, you reduce the zone, you improve FBA. But in terms of CSF, at least I can comment CSF, what we observe is you can get an abnormal ratio, p-tau Aβ42 ratio, while the p-tau is well below the positive cutoff. So in other words, because your ratio depends on 2 numbers, if your A-beta down to, we are using the Roche test, if your A-beta down to 500, 600, your p-tau can stay 20 or even less than 20, and your ratio up will be AD. So I like your comment to see what you see in your hand, and we also know the patient. From our other study, from our core study, we know those are PET negative. So if you look at ratio, it's Alzheimer PET, not Alzheimer. So I would like to hear your experience about using the ratio solely as a ratio alone to classify your sample status.
I think one, Another disadvantage of using the ratios is that you lose information, because if you have phospho-tau on the one side and Aβ42, you have two biomarkers that are giving information. If you put it in a ratio, you are losing information. So I think it's always good, and it's what I do with the CSF, is to look at all the biomarkers. And yeah, things are sometimes complicated, are not black and white, and you have to interpret these biomarkers in the clinical context. And there are things that we know that can increase a lot the taus, like Creutzfeldt-Jakob disease, or can also interfere with Aβ42. So you have to interpret it in the clinical context. And maybe the ratios can be useful in order to, when you have the other picture, well, maybe it's in the end to have a final decision. But I think it's always good to look at all the single biomarkers, because otherwise with the ratio you are losing in information. That's what I would say.
So thank you so much, and you've shown nicely the huge progress that has been made over the years. And yeah, I thank you for your attendance and actually staying overtime. And yeah, give a hand to our great presentator. And I wish you a great conference.